Hello and welcome to this internet webcast titled Reducing Allergic Manifestations in Children with Cow's Milk Allergy, Current Research. This certified webcast provides continuing education credits for physicians, nurse practitioners, registered nurses, and registered dietitians. A link to submit for CE credit is provided at the conclusion of this program. If you are listening today as part of a group, you may find it more convenient to submit for CE credit by downloading the group sign-in sheet and the CE evaluation for this activity. Both documents are available on our website, pediatricnutritionce.org, and we will repeat this information at the conclusion of the webcast. It's now my pleasure to introduce our speaker, Professor Roberto Berni Canani, MD, PhD at the University of Naples. He is Chief of the Pediatric Allergy Program in the Department of Translational Medical Science and the European Laboratory for the Investigation of Food-Induced Diseases. Dr. Canani will answer questions at the end of the live activity. Dr. Canani, you may begin your presentation.
Hello, welcome to everybody. I'm Roberto Berni Canani, and today I'm pleased to present our most recent research results on a relevant problem for the pediatric age, cow milk allergy. Worldwide, cow milk allergy is one of the most common food allergies in childhood. The prevalence and severity of the clinical manifestation of cow milk allergy increased at an alarming rate in the last years. In Italy, in my country, in the last 10 years, we observe a 500% increase in the number of children requiring hospitalization for cow milk protein-induced anaphylactic reactions. Cow milk allergy derives from a defective oral tolerance mechanism leading to an abnormal immune-mediated reaction against cow milk proteins, which in turn could induce an IgE-mediated or a non-IgE-mediated mechanism. Another important aspect is that cow milk allergy is now recognized as the first indicator of a dysregulation of immune system in children. In fact, babies with cow milk allergy have an increased risk to develop other allergic diseases later in their life, the so-called atopic march. The first-line treatment for all children affected by food allergy is the elimination diet. But the peculiarity of cow milk allergy is that in this condition, we can use different formulas, including exencyl-lysic casein or whey formulas, soy or rice-based formulas, or amino acid-based formula. We recently showed that in children with cow milk allergy, the use of an innovative dietary strategy based on exencyl-lysic casein formula supplemented with the probiotic LGG is able to induce a faster acquisition of immune tolerance. In recent years, together with other research groups in Europe and United States, we have focused on the mechanism of action of this innovative dietary strategy. Preliminary data suggests that this dietary strategy exerts positive effects on gut microbiota composition, short-chain fatty acid productions, in particular butyrate, a very potent short-chain fatty acid that exerts many effects at the immune system level, in particular driving epigenetic modification of the mechanism of immune tolerance, and a well-tuned epigenetic regulation of gene involved in the allergic response. Such mechanism suggests a possible long-term effect elicited by this new dietary strategy on the immune system of a child affected by cow milk allergy. So our most recent research activity was focused to test whether this innovative dietary strategy based on exencyl-lysic casein formula supplemented with the probiotic LGG could influence the occurrence of other allergic manifestations in children affected by cow milk allergy. And we evaluated IgE-mediated cow milk allergy patients because these subjects are at an increased risk to develop other atopic manifestations. We designed a randomized controlled trial. The primary outcome of this study was the occurrence of any atopic manifestation during a 3 years follow-up, in particular eczema, urticaria, asthma, and rhinoconjunctivitis. The secondary outcome was the acquisition of immune tolerance after 1 year, 2 years, and 3 years of dietary treatment. The parallel arm randomized controlled trial was designed to test whether Allergic casein formal supplement with the probiotic LGG can reduce the incidence of other allergic manifestations compared to an Allergic casein formula not containing the probiotic in children with IgE-mediated cow milk allergy. The trial was performed in collaboration with family pediatricians who care for children up to the age of 14 years in the Italian National Health System. Before to start the study, all involved family pediatricians attended an investigator meeting where the study protocol was illustrated and discussed, and all the procedures and definitions were shared. The inclusion criteria were age between 1 month to 12 months and suspected IgE-mediated cow milk allergy. The exclusion criteria were cow milk protein-induced anaphylaxis, food protein-induced enterocolitis syndrome and other food allergies, other allergic diseases, no cow milk allergy-related atopic eczema, eosinophilic disorders of the gastrointestinal tract, chronic systemic diseases, congenital cardiac defects, active tuberculosis, autoimmune diseases, immunodeficiency, chronic inflammatory bowel diseases, celiac disease, cystic fibrosis, metabolic diseases, malignancy, and chronic pulmonary diseases, and malformation of gastrointestinal or the respiratory tract, and administration of prebiotics or probiotics during the 4 weeks before the enrollment. Only subjects who met the inclusion criteria were invited to participate to the study. Anamnestic, demographic, and anthropometric and clinical data, as well as information on socioeconomic factors, family and living conditions, parental history of allergic diseases, maternal smoking during pregnancy, environmental tobacco smoke exposure, and number of siblings and pet ownership were obtained from the parents of each infant and recorded in a specific clinical database. Then we perform skin prick tests, and according to a randomization list prepared by a biostatistician who was not involved in the statistical analysis, infants were randomly allocated to one of the 2 groups of dietary intervention. Group 1 received Allergic casein formula alone, and Group 2 received Allergic casein formula containing the probiotic LGG. From 2 weeks to 4 weeks after the first assessment, when a full and stable remission of cow milk allergy symptoms was achieved, a double-blind placebo-controlled food challenge was performed. The recruitment of children continued until a pre-specified number of 110 subjects per group with cow milk allergy was achieved, and only these subjects continued the exclusion diet using an hypoallergenic formula prescribed at the randomization and started the trial. Then, during a 3-year follow-up, at least 3 visits, at 12 months, at 24 months, and 36 months after start of the study were performed. Skin prick tests and oral food challenge were performed to explore tolerance acquisition to cow milk every 1 year, and clinical tolerance acquisition was defined by the presence of a negative oral food challenge. Children with a negative oral food challenge at any subsequent visit were reevaluated after 6 months to check the persistence of oral tolerance acquisition. Only children with a negative food challenge at any follow-up stopped the consumption of the study formula. And unscheduled visits were made when the family pediatrician noted any allergic symptoms. At each visit, the children were examined by the family pediatrician, body growth was assessed, and a structured interview on health problems, including allergic symptoms, was carried out. All diagnoses of other allergic manifestations were performed by a tertiary center by 2 investigators, blind to the group assignment. In the case of discordance about the atopic manifestation diagnosis, further evaluation by a 3rd pediatrician experiencing pediatric allergy was performed. Clinical tolerance acquisition was defined by the presence of a negative oral food challenge, and children with a negative oral food challenge at any subsequent visit were reevaluated to check the persistence of oral tolerance acquisition, and only children with negative oral food challenge at any follow-up stopped the consumption of the study formula. As you can see here, all allergic manifestations were diagnosed by the family pediatrician using standardized criteria. This is the flow of subjects during the study. Because children had to have a double-blind, placebo-controlled food challenge confirmed diagnosis of cow milk allergy, we increased the pool of children allocated to the two treatments, and we designed the study to enroll up to 150 children per group, until at least 110 children per group had a double-blind, placebo-controlled food challenge and confirmed diagnosis of cow milk allergy. A total of 27 children were lost during the follow-up, 15 in one group and 12 in the Exploratory case informal supplement with the LGG group. These are the main demographic and clinical features of the study population. As you can see here, at the baseline, all main features of the study groups were similar. All children were from families of middle socioeconomic status and lived in urban areas. In this figure is depicted the main study outcome under complete case analysis. The results of this randomized controlled trial show that extensive case informal supplement with the probiotic LGG is more effective than extensive case informal alone in preventing the occurrence of other allergic manifestations. The number of children needed to be treated with extensive case informal with the probiotic LGG to prevent the occurrence of at least one atopic manifestation during the 3 years follow-up is 4. All these data strongly support the beneficial effect elicited by this innovative dietary strategy. As you can see here in this slide, a similar trend was observed for all the components of the main study outcome, with significant absolute risk difference between the two groups, suggesting that this innovative dietary strategy based on extensive case informal with the probiotic LGG inside is more effective than extensive case informal alone at preventing the occurrence of eczema, asthma, urticaria, and ocular rhinitis. An additional evidence on the positive effect of this innovative dietary strategy on oral tolerance acquisition has been provided in this study. As you can see here, as 12, 24, and 36 months of follow-up, an increasing rate of children acquiring oral tolerance was observed in patients treated with extensive case informal with LGG. These data are of relevance considering the most recent evidence suggesting that the natural history of cow milk allergy has changed over time, with an higher proportion of children with disease persistence through 5 years and subsequent ages. As you can see here, data on a skin prick test for whole cow milk parallel that observed for tolerance acquisition. In fact, at 1 year, 2 years, and 3 years of follow-up, patients treated with the extensive case informal supplemented with the LGG showed an increased rate of negativization of skin prick test. We guess that our study has several strengths. First of all, it is a randomized controlled trial that was performed on a large sample of children with challenge-proven diagnosis of cow milk allergy, followed at a tertiary center for pediatric allergy with a high follow-up rate. Second, the effect sites associated with both the primary and secondary outcomes were clinically relevant. Third, such effect sites maintain a clear trend toward benefit under the worst-case scenario sensitivity analysis. However, as expected, our study has some limitations. First of all, our data cannot be generalized to children with conditions that were a reason of exclusion from the study, for example, anaphylaxis. The effect of extensive case informal supplement with the LGG versus extensive case informal alone in these children will have to be addressed by future studies. Second, although our results show that this innovative strategy reduced the incidence of other allergic manifestations and favored the development of oral tolerance in children with IgE-mediated cow milk allergy. After 1 year, 2 years, and 3 years of dietary, longer follow-up times are needed to test whether this effect persists over long term. Third, our results are limited by the lack of data on gut microbiota and Th1, Th2 cytokine expression, which would be useful to investigate the mechanism by which extrinsic casein format supplemented with LGG can produce its effect. So we can conclude say that our actual approach is to counteract step by step all factors involved in cow milk algae pathogenesis, modulating the interaction among dietary factors, gut microbiota composition and function, epigenetic mechanism, and immune system activity. And what we found is that extensively casein formula supplemented with the probiotic LGG is very active on all these pathways. The final result of this modulation is a downregulation of allergic response, and this positive mechanism drives to a faster acquisition of oral tolerance and a sustained protection against other atopic manifestations in children affected by cow milk allergy. Thank you very much for your attention.
Thank you, Dr. Canani. Our first question from a participant: are there any data that suggest dysregulation of the microbiota in infants who later develop CMA?
Yes, we have evidence suggesting that gut dysbiosis precedes the cow milk allergy and influences during early life the subsequent development of other allergic conditions. In fact, it has been shown that some alteration in gut microbiota composition and function in the first months of life, the so-called dysbiosis, correlates with subsequent occurrence of food allergy in later years, suggesting that early gut dysbiosis contributes to subsequent development of food allergy. There are epidemiological studies that have established a clear correlation between factors that disrupt, that modify the gut microbiota composition during childhood and the immune condition later in the life. Several factors responsible for dysbiosis have been associated with the occurrence of a food allergy, such as, for example, cesarean delivery, lack of breast milk, drugs used, mainly antibiotics and gastric acidity inhibitors, antiseptic agents used, and a low-fiber, high-fat diet. And it has been demonstrated that neonatal antibiotic treatment reduces microbial diversity and bacterial load and enhances food allergy sensitization. In fact, maternal use of antibiotics before and during pregnancy, as well as antibiotic course during the first months of life, has been associated with an increased risk of cow milk allergy in infants.
Our next question: did you find any differences in weight gain or growth between the infants who received LGG and those who didn't?
No, we didn't observe a difference comparing body growth rate in children treated with extrinsic casein formula supplemented with LGG or with extrinsic casein formula alone. The changes in body weight and length or height were similar in the two groups.
Should extensively hydrolyzed formula be used prophylactically in infants with a sibling who developed cow's milk allergy?
Yes, there is evidence suggesting that in not breastfed babies, a possible cow milk allergy prevention strategy could be based on the use of extrinsic casein formula. But this is a very dynamic field, and more studies are necessary to better define the potential of this strategy or the use of extrinsic casein formula supplemented with LGG on cow milk allergy prevention.
And our last question: there was a similar study in JACI several years ago that showed a combination of Lactobacillus casei and Bifidobacterium did not improve tolerance to cow's milk allergy, and this was surprising to me because I thought combinations of probiotics would be more likely to have an effect. Now, I also know there is a variability in individual formulations of EHF and probiotics. Given the results of your study and this other study, do you think there's something specific to Lactobacillus GG, or could the effect on tolerance be dependent on the specific combination or preparation of probiotic and EHF?
Yes, it is now clear that the many effects of probiotics on the immune system are strain-specific. study conducted with other lactobacillus species did not obtain comparable results. Thus, if you like to target the immune system of a baby affected by cow milk allergy, for example, using a probiotic, it is important to be prudent using only selected probiotic strains at a particular dose. In particular, the specificity of LGG is related at least in part to the fact that this particular probiotic is able to produce more than 300 strain-specific peptides and a particular DNA sequence that are recognized by our immune system and promote an anti-allergic response. In addition, we know now that LGG is able to shape gut microbiota composition and function, increasing the number of butyrate producer bacterial strains that regulates positively the mechanism of immune tolerance. And we feel that our results could derive, at least in part, by this nice mechanism of action, is it by LGG, and direct effect or small casein-derived peptide on our immune system.